Aloha, everyone. Good evening. I want to welcome you to Queen's Free Speaking of Health lecture series. Tonight's lecture is called The Way to Better Bone Health. My name is Lisa Sakia. I'm with Corporate Communications, and on behalf of the Queen's Health Systems, I welcome you this evening. All right, so I'm going to introduce our four speakers this evening. The first person I want to introduce you to is Dr. Kevin Christensen, orthopedic surgeon. If you could stand. He was born in Moorhead, Minnesota, and grew up in Dallas, Texas. He played Division I football while obtaining his bachelor's degree at the United States Military Academy at West Point. He completed his medical school at the University of Texas Health and Sciences Center at Dallas Southwestern Medical School. He followed this with a residency program at Brooke Army Medical Center in San Antonio, Texas, and a fellowship in orthopedic traumatology at Southwestern Medical Center and Parkland Memorial Hospital in Dallas. In 1989, he served as Chief of Orthopedic Surgery at Tripler Army Medical Center. After a deployment to Desert Storm in 1991, he returned to Dallas, practicing at the University of Texas Southwestern Medical Center. In 2007, he returned to the islands, and he joined a private orthopedic practice at the Bone and Joint Clinic of Hawaii, and he is currently the Chief of Orthopedics here at the Queen's Medical Center. He is passionate about the education, early treatment, and improvement of bone health. That is Dr. Kevin Christensen. Next up, I'd like to introduce you to Mary Mitsunaga, who is a fragility fractures expert. Mary obtained her bachelor's degree in biology at the University of San Francisco. She received her master's degree in nursing at California State Dominguez Hills in Torrance, California. She did her nursing training at the University of California, Davis. She has experience in various clinical trials, orthopedics, and geriatrics. Currently, as an advanced practice nurse, she sees patients with fragility fractures here at Queen's Punch Bowl. That is Mary Mitsunaga. Next, I'm happy to introduce you to Dr. Britta Aramaki, who is a geriatrician here at Queen's. She was born in Honolulu and grew up mostly on the mainland. She had obtained her bachelor's degree at the University of Texas in Austin and received her master's degree in public health from the University of North Texas Health Science Center in Fort Worth. She moved back to Oahu in 2007, where she completed medical school, internal medicine residency, and a geriatric medicine fellowship at the University of Hawaii John A. Burns School of Medicine. She is currently practicing at Queen's, providing inpatient geriatric consultations. Her interests include practicing inpatient geriatric medicine, incorporating palliative care early on in chronic disease, and improving transitions of care in the geriatric population. That is Dr. Britta Aramaki. And finally, I'd like to introduce you to Jeremy Angaran, who is a physical therapist. You can tell he practices what he preaches there. Jeremy was raised in Corvallis, Oregon. He did his undergraduate studies at Willamette University in Salem, Oregon. He received his Doctor of Physical Therapy degree from the University of Puget Sound in Tacoma, Washington in 2002. In 2009, he moved to Honolulu with his local girl wife, whom he met in Tacoma, Washington. He currently serves as manager of 3 departments here at Queen's: Outpatient Rehabilitation Services, the Pain and Spine Center, and the Center for Sports Medicine. That is Jeremy Angaran. We're going to start off with Dr. Christensen.
Press the button. Okay, hi. Thank you, Lisa. Thank you for coming. Great crowd tonight, okay? I think they wanted me to start first, okay, so to scare and get your attention, okay, because you really don't want to meet me, all right, you really don't, okay. Maybe at Alamoana or someplace like that, but you don't want to meet me here. I have all kinds of things that happen when you break your bone, and this is a silent disease, and I'm glad you're here because this is when you need to make the adjustments and understand that before you fall, and that's what the rest of the people do. So that's what, Britta's going to tell you about, that's what Mary's going to tell you about, Jeremy's going to tell you about, but I'm just to get your attention to say, this is what happens if you break a bone, all righty? And that's what I'm going to be doing. So osteoporosis and osteo-related fractures, they're different than, say, a moped or a car accident or a fall from a roof. They usually just cause when you fall from standing, okay? And it's a thinning of the bone. I have my two models up there, the one that's all crunched down and it's got no interstices of the bone and is real thinned is the osteoporotic bone, and then the strong bone, you can't hardly see through it. And that's what osteoporosis is. The bone gets weak because it just doesn't have enough end structure, so things break. And we have medications. Mary's going to go over those. And then polypharmacies, you want to only take what you need, and then we're going to talk about fall prevention tips with Jeremy, which I think is better than any medicine, okay, is make sure that you don't fall, okay, and so he's going to give you some tips on that. So a fragility fracture, what on earth is that? We just, when I teach the residents and everything, it's just like, hey, you fell down and you broke something you shouldn't. Typically one that breaks are your wrist, your spine, your vertebral body, your pelvis, and your hip. And it's just because you just fell down, and it wasn't because you were riding your moped. And it's because your bones are a little bit brittle, and since they're osteoporotic. Now, this is my favorite slide, okay, because it's a big deal. All right, all the cardiologists think they're cool. All right, the neurologists think that they're strokes, but it says I own the biggest bar line, okay. All right, the fragility fractures are enormous, and they're an enormous expense to the healthcare system, because if you fall and break things, you have pain, you have to have surgery frequently, and it's a really big deal, all right? And a lot of people don't know it. And then I always say to the residents who may want to do fracture works and do studies, everybody in Hawaii lives forever and they take their medicines, and so there is a particularly, my practice in Dallas at Parkland was much different than my practice here. We had gunshot wounds and, kind of crazy things and all like that. Here I have, a hip fracture about every night, and I have pelvic fractures and spine fractures, and people get admitted for that, and it hurts. So we own, the big bar line, and so I want you to listen to what the people say so you don't have to meet me. That's the big deal, all right? And then we're going to go over here. The big ones that bother people are the spine. Now, you usually don't have to have it, but it hurts. You're all of a sudden you fell down and your back hurts, and that's because it's squinched down, and it takes about 3 months to heal, and that's kind of miserable. You don't want to have a hip fracture, and there's a lot of them. And the bad thing about the hip fractures is not only does usually have to have surgery, but it's kind of dangerous. It's kind of risky. We do everything that we can to make sure you sail through it. And if you've ever had a wrist fracture, it hurts a lot, and you can't comb your hair, and it's just kind of a mess. So those are the common sites. The pelvis is kind of an interesting one. When you look at our little diagram here, the hip is this area right here. The hip is that area right there. The pelvis is all this big wing bone, the iliac, and all like that. That's what breaks, and it breaks just really a lot. All right. So it happens both in men and women. So the guys, I'm glad you're here. And it happens more in women, but the guys get it too. And then the highest incidence of hip fractures this I didn't know. Mary found this out for me, but I didn't realize. But the U.S. we lead the world in hip fractures already. Maybe it's because we can live longer here, but it is an epidemic, and that's why I'm here to tell you that. And again. It's dangerous. If I have to do surgery, it's not without, problems. And we talked about it in our morbidity and mortality conference this morning. So the big thing that I wanted to go is the last thing that you see here. If you have a fragility fracture, if you fracture your spine, if you fracture your pelvis, if you fracture your hip, if you fracture your wrist, you have a really high likelihood of having another one. So, it just happens, all right? I mean, it's not uncommon for me to fix one hip and then 6 months later the other hip breaks, okay? Or the pelvis fracture and then they fall again and they break some in their back. So there are things that we want you to if you have fracture, then get on it and then make sure that you don't do another one. That's why I'm here, is to scare you into listening to what Britta and Mary and Jeremy are going to say, Audie, if you have it. So it's the wake-up call, Audie, to do something about it. So everybody says, well, what's the hip and what's the pelvis? So here's the diagram. The big one is the hip. There's the femoral head, the neck, and the greater trochanter. The pelvis is all this big thing that goes around in there, and the acetabulum is the sock that fits in there. So this is what happens a lot. You can get the hip fracture is probably the most common thing that we have to treat surgically. It can break at the neck. Can break at the intertrochanteric area and the subtrochanteric area. Here's one that got a little bloody stuff in it, so make it a little more dramatic. Already, and then there's this other thing that's kind of weird in orthopedics. We talk a lot about, but it's atypical femoral fractures. Normally is what I just showed you, which was femoral neck fracture, intertrochanteric fracture, and subtrochanteric fracture. But now we get these ones that are down like this. They're frequently, sometimes loosely associated with the bisphosphonates, which are one of the medicines that we sometimes use to treat osteoporosis. But it happens just from getting off the toilet and that sort of thing. So that's just sort of a normal thing. We'll talk more about it in the panel discussion. But it's a stress fracture. It's due to bisphosphonate use, which is a medication that's used for osteoporosis. It's quite rare. It's not a reason to say, oh, I'm not going to take my bisphosphonates anymore. But we'll talk about how long and whatever later on in the program. And then the other thing that you got to worry about is if you take a lot of steroids for like lupus, rheumatoid arthritis, that happens. Hypothyroidism, low vitamin D levels. We were looking at that. This is a big deal too. A lot of the people that we draw the vitamin D levels on everybody that has a fragility fracture in the hospital that comes in on the fragility fracture service, and many of the people are vitamin D deficient. So it's a pretty safe medicine to take. Now, Mary told me about all this, and I'm going to have to kind of wing it here a little bit, but this is a fancy thing to say. You should take, if you're prescribed your bisphosphonates, if you're just prescribed medicine for the fragility fracture, take your medicines, because you got a very low risk, less of a risk of a fracture if you take your medicine, and then the risk of complications from the bisphosphonates is much, it's lower if you take it. There's less fracture. By and large, the whole big studies all across the nation says if you take your medicines appropriately and right in bisphosphonate, the fracture risk is lower. So that's what these two things mean, I think. Did I do that all right? Okay. All right, okay. There's a lot of smiley faces, okay, so what? What are the symptoms of this bisphosphonate stuff? It can be, it's very frustrating pain. It can be from the hip and down. It's mostly in the thigh. And then you don't, you go to your doctor and they say, well, you don't have much arthritis in your hip, so it's very frustrating when you have it. But all it really takes to figure it out is usually an X-ray and a history. But the pain is kind of elusive to run down, and it can make it where it's unable to walk. That's a pretty bad one. So here's all the things that we do. We'll use different things to fix the femoral neck fracture, we want to fix them so you can kind of get up and walk. Sometimes we do other bigger things, like we do hemiarthroplasty, which is half a total hip or a full total hip, and that's sometimes if you have arthritis that's associated with. We want to do it. We want to get on it early so you can mobilize, which means get up and walk, and you don't get blood clots, you don't get pneumonias, but it is a bigger surgery, and it's usually just on displacement. And then these are some of the intertrochanteric treatments. We use hips and screws, different things. We argue about whether we should use this or this when we go to our big orthopedic meetings, okay? And we always worry about infection, respiratory things. Now, this is why you're supposed to listen to them, is because I have to worry about this stuff, which is infection, respiratory issue, blood clots, fractures below the implants that we use. But the big part about it is, and it's really true, is it's dangerous. This is dangerous injury, a dangerous surgery, because if you have it, and 25% of the folks can pass away within a year. So it's not, and then usually you'll lose a level of mobility if you have it. So don't meet me, okay? Do what they say, okay? So you don't fall. Everybody, anybody been my patient, I have two things I say: don't fall, okay? And then if it hurts a lot, don't do it, okay? So that's my thing to say, to do what they say, which is, don't trip over anything, don't take a lot of medicines, okay, and get loosey-goosey and dizzy, okay, and fall. And so that's an orthopedic way of saying quickly, don't fall, and if you hurt a lot, don't do it. Okay, so now I'm followed by Mary. Mary's up next, okay? So, thank you.
Thank you, Dr. Christensen, and thank you, everyone, for coming. Trust me, you don't want to see Dr. Christensen, and no, I'm just kidding. He's a great guy, kind of scary, though, with the things he talked about. You don't want to have fractures. So I'm here to tell you how you can prevent that from happening to you. So I do want to start by sharing some cases with you, some typical patients that we do see here at Queens. This is an actual patient we had. I'm not going to share with you her real name, but we can call her Mrs. Doe. She is a 75-year-old female. So back in March 2006, about 11 years ago, she was only 65. She had a left hip fracture. She went to Asia to visit her family, and she slipped over uneven pavement and fractured her hip. Then she got it fixed. She saw someone like Dr. Christensen, who fixed it with implants and all that, and she did a little bit better. In 2009, though, in December, she broke, that same area, that hip again. Just under the implants, and that's what we call periprosthetic hip fracture. So even after you get even after you have hip surgery, you can still fracture around that implant if your bones are brittle. And unfortunately, in June 2010, she had another fracture, and this time is in that area, the pelvis area, that iliac wing, that Dr. Christensen showed you, so another part of her body. And in August 2016, that's when we saw her. That's when I saw her. And this time she didn't fall. She simply bent over. She said she bent over. She was picking something up, and then started to have some back pain. So she went to see her doctor, and they found that she had compression fracture in the spine. And so when I saw her, I asked her, you had a lot of fractures, where you told you have osteoporosis. Did you start on any medications? She actually said, I didn't think it was related to osteoporosis. I thought, I fell, and so I broke a bone. She also, wasn't really sure why she didn't take medications, but she said, well, I had surgery. It was fixed, so I thought it was okay. I didn't have any more pain, so, it was fixed. I had surgery. But what she didn't know is surgery actually doesn't fix, will fix the broken bone, but it doesn't fix the osteoporosis. You can still, go on and break other parts of your body if you have brittle bones. So let's talk about osteoporosis. What is that? So it is thinning of your bones, which, like Dr. Christensen said, you have less of that bone density, and you're, prone to breaking your bones. It's also a silent disease. A lot of times you don't know you have it until you break something. That's when you have pain, and that's when you know it. So here's a picture of what a normal bone should look like. Very dense, this here. And here is a picture of what osteoporotic bones will look like. So, you see all the holes, it's brittle, it's easy to break, kind of like a Swiss cheese, if you will. So let's talk a little bit about what happens in your body with osteoporosis and the normal bone remodeling process, and what the difference are. So in our bodies, we have osteoclast cells and osteoblast cells. So basically, in simple terminology, osteoclast is responsible for breaking down mature bones. So in our body, we have mature bones, we have old bones. The osteoclast will get rid of it, and when it does that, it removes those mature bones, and then it forms these cavities or holes in your bones. Osteoblasts are responsible for building new bones, and what it does is then it deposit new bones into those cavities in our bones. But in osteoporosis, osteoclast works a lot faster than the osteoblast cells. So we have those cavities, we have a lot of those cavities, those holes, but osteoblast is not working fast enough to deposit new bones, and that's why in osteoporosis we have these holes in our bones, and they're easier to break. So they're not as strong. So I want to show a video of a patient who experienced these fragility fractures and what she learned from it. And then we'll move on to. So just kind of remember her story. We'll refer back to it as I go on with the program.
I was in the medical field as an x-ray technician for about 30 years. I started the bone density tests about 15 years ago, and all of them showed just osteopenia.
And for your age, it was normal.
Yes, exactly. That's how the report would come back, normal for my age. I was a very active person. I loved to play golf. I took care of grandchildren. I gardened. I exercised every day. I walked every day. And these are things that I love to do, but I just can't do them now. I thought I was coming down with just a bad cold, and I just started coughing, and I coughed so hard that I almost fell to the floor, and I could feel a severe pain in my lower back. We went to the ER, and they did an MRI and found out that I had a fracture of L4. So I had surgery on that and followed up with an orthopedic doctor, and he indicated that I had osteoporosis because he said there's just no way that I could fracture a vertebrae by coughing if I didn't have osteoporosis. And also, once they got in and saw my bones, they could see how soft they were. I don't think people really realize how bad osteoporosis is, because it is such a silent disease until they actually get it themselves.
But you know, it changes your family so much that, you know, grandkids used to love to come and run to grandma and hug her, but the first time that they came, I says, you know, you can't do that. You gotta just touch grandma very softly because you can't squeeze her. And, you know, that
Which
hurts
is
to say
hard
that.
for them to really understand that at that age, you know. My hope is that I'm going to be able to build some new bone mass and be able to do all the things that I really loved to do before.
I'll be able to get my golf partner back, because that was something that we really enjoyed doing together. You know, a lot of guys don't like to golf with their wives, but we really enjoyed doing that together, because we'd go on golf trips out to Arizona, and you know, we just do that. So I hope I can get her back. So hope that works out.
All right. Let's go back. All right. So Mrs. Renke, you know, she didn't know she had osteoporosis. She had a bone density scan that showed osteopenia, and I'll go over a little bit what a bone density scan is and what osteopenia is. But you know, so she didn't have any signs and symptoms of osteoporosis until she had that severe cough, and she broke her spine in the L4 lumbar region, and felt pain. That was her, you know, symptom of osteoporosis. Loss of height can be another symptom of osteoporosis or a sign, and that's when you're, you know, in your back, when your bones are broken, it compresses and collapse, and so you can have that loss of height. So who gets osteoporosis? So like, you know, Dr. Christensen said, women and men both get osteoporosis, and more so in women, but men do get it. So I'm glad to see some men here. So 1 out of every 2 Caucasian women will experience osteoporosis-related fractures, and 1 in 5 men, Caucasian men, will as well. Here in Hawaii, we have a huge population, you know, of Asian Americans. So Asian American women are also at risk. About 50% will experience osteoporosis-related fracture. And it's very interesting that we found in literature that actually 90% of Asian American women are lactose intolerant. And, you know, milk and dairy products have calcium and vitamin D, and I'll kind of cover that in a little bit. And who else are at risk for osteoporosis? So we mentioned Asians and Caucasians. Postmenopausal women. So when we go through menopausal changes, hormone changes, we have an imbalance in hormones, and that can affect those osteoclast and osteoblast cells. And people who have a sedentary, you know, lifestyle, who don't exercise, in particular resistance exercise, and Jeremy will cover a little bit more about what, you know, type of exercise are important for you. Smokers and heavy alcohol users are also at risk for osteoporosis. Long-term steroid use, so things like medications like prednisone, seizure medications can also put someone at risk for osteoporosis. And if you had a parent with, so your father or your mother who had a history of a hip fracture, can also put you at risk for fractures related to osteoporosis. So what can you do about it? How do we know you have thin bones or osteoporosis? So bone mineral density scan is one way. This is what the machine looks like. It takes about 10 minutes for the procedure. And then we get these T-scores, and it tells us how thin your bones are or whether they're normal. So bone mineral density scan is also known as DEXA scan, D-E-X-A, or DEXA, spelled D-X-A. And that's just the name of the test, and different radiology departments or clinics will just kind of use different terminologies. But bone mineral density scan is what general term is. So if you have a T-score, if you look over on the side, +1 to -1 is a normal T-score. You have normal bones. -1 to -2.5 is osteopenia, or also known as borderline osteoporosis. So you have some thinning of your bones, you're leading to osteoporosis, but you're not quite there yet. And that's what Mrs. Renke had, right? Osteopenia. -2.5 or lower is osteoporosis. So you do have thin bones. So who should get bone mineral density testing? For the general population, for prevention, just for screening purposes, all women age 65 and older should get one. Men should get it too, age 70 or older. You can also get the scan a little bit earlier if you have risk factors, like if you had a history of fracture without major trauma, so you didn't fall from a roof or was involved in a moped accident. After age 40 or 45, you can get the scan earlier. And if for any reasons you had an X-ray or a CT scan and it showed osteopenia or signs of thinning of bones, you can also get the bone mineral density scan a little bit early. If you're on long-term steroid use, if you have family history of osteoporotic fracture, early menopause, current smoking, excessive alcohol use, and if you're on some type of seizure medications, you can also get the bone mineral density scan a little bit earlier. So even if you have a normal bone mineral density scan, you should still be monitored and get it every 2 years just to make sure it stays normal, whether it's becoming osteoporotic, and your provider can do something for you. Another tool that providers use is called a fracture risk assessment tool. It's also known as FRAX, F-R-A-X. So with Mrs. Renke, she was she had osteopenia, but she wasn't started on medication, so osteoporosis medication. But if we use this tool, it can help us determine your risk of fracture in 10 years. And it incorporates those risk factors like steroid use, smoking, alcohol, heavy alcohol use, seizure medications, rheumatoid arthritis. We incorporate those things, we'll get help us obtain a FRAX score. So if let's say you have osteopenia and you have a high FRAX score, that can tell us that you should probably consider osteoporosis medications and other things to prevent osteoporosis. So you don't want to wait, too long. You don't want to look into treatment too late. You want to try to prevent getting osteoporosis. And this tool can help us determine that for you. So other things, if you do have the osteoporosis, calcium, vitamin D are important for our bones. But if you don't have osteoporosis, it's also important for bone development in kids, teenagers, and an adult without osteoporosis. So here are the daily requirements, calcium requirements. You can also get calcium in food products, right, in food and beverages. And we'll kind of go over different types of food that you can get it from. So in an average American, we can get half from food intake and half from calcium supplements. Unless you eat very, very healthy and you're cognizant of what you're eating, how much calcium is in certain food products, you can probably get it all in food products as well. So I'm not going to go over the whole list, but here is a list of different types of food that you can get calcium and the amount and how much calcium it contains. Common questions that I get from people, one of the common questions is with milk. Is there a difference of calcium content with low-fat milk or skim milk from whole milk? And the answer used to be, yes, there is a difference. When you remove the fat, you also remove calcium and vitamin D contents. But nowadays, low-fat, skim milk, they add vitamin D and calcium. So just look at the carton of milk to see whether the vitamin D and calcium are added. Soy milk is another question. Well, does soy milk have calcium? Yes, it actually does. So here's a list. If you want a more complete list, you can go onto National Osteoporosis Foundation website to find a more complete list of calcium food products. Spinach and broccoli is also, it also has calcium in it. So I do want to talk a little bit about the different types of calcium out there. Calcium carbonate, calcium citrate is one. There's plenty more out there, but just want to touch on two of the common ones. So calcium carbonate usually has the highest concentration of calcium per pill, meaning it contains about 500 or 600 milligrams per pill. So you would have to take less of pills if you take calcium carbonate. Citrate usually contains about 200 milligrams or 315 milligrams per pill, so you might have to take more pills to fulfill that calcium requirement daily. But nowadays, citrate, I've seen over the counter that they're starting to make it in a higher concentration pill. So just look at the labels to see how much calcium content is in per pill. You do have to take calcium in divided doses because our bodies can only absorb so much calcium, about 500 to 600 milligrams of calcium in one sitting at one time. So if the pill bottle says take 2 tabs daily, don't take 2 of them at one time. Some people think I'm just going to take 2 and I'll be done with for the day, but you're only getting half of it if you're taking 2 of it. So take 1, in the morning or lunch, and then take 1 during dinner time. Calcium carbonate. So the carbonate form does require an acidic environment for it to dissolve, for us to absorb it. So if you're taking acid reducers like Zantec or Pepsid, you may not be absorbing the calcium appropriately. So you may want to take your acid reducers earlier in the day and split up, the calcium. Or you can find the citrate form. That doesn't require that acidic environment. There are some side effects with calcium supplements. Some people think, well, they're supplements, there's no side effects, but it can. Calcium carbonate can increase your risk of constipation. So it can cause constipation for some people. And in the form of citrate, it can increase your risk for kidney stones. Okay, so with, I've mentioned, look at the labels of the pill bottles. So we'll kind of talk about how do you analyze and interpret those values, those numbers on food labels and pill bottles. So if you're taking calcium and it says, well, it has 30%, it usually lists the percentage, right, of the daily value, 30% of calcium. Well, how much is in 30% of calcium? So just remember these examples. It's based off of 1,000 milligrams of calcium per day. So if it says something like 30% DV of calcium, that means it's 30% of that 1,000, which equals to 300 milligrams of calcium. So that's, it's not nearly enough of calcium. So just remember to read those labels and keep track of how much calcium is in the food or the multivitamins is another thing. A lot of people say, well, I don't take extra calcium. I have calcium in my multivitamins like Centrum or something like that. But usually it's not enough. It's usually 12% or 30%. So you might have to take extra calcium, a separate calcium pills. So vitamin D. We also need vitamin D for our bones. It helps our bodies absorb calcium a little bit better. And we found that, with our hip fracture patient, 80% of them had low vitamin D levels. And it's important for our bones, for our muscles, and it's also linked, so new studies have found that low vitamin D levels are actually linked to falls. So how much vitamin D do we need? So for the general population, about 800 to 1,000 international units per day, which is equivalent to 5 ounces of salmon or swordfish every day, or 20 eggs a day. Yeah. So if you eat 20 eggs a day, you might have really high cholesterol, and that's another problem, right? Yeah. So, or 1 gallon, and this is, if you don't remember what 1 gallon, this is 1 gallon of cream of mushroom soup. I don't know about you, but I'm lactose intolerant too, so I wouldn't want to do that. Or you can take a vitamin pill, just 1 vitamin pill. You may need a little bit more or higher dose of vitamin D supplement if you do have lower than normal vitamin D levels. So like Dr. Christensen mentioned, we do check vitamin D levels for all of our fragility fracture patients, and we supplement their vitamin D according to their lab values. So let's talk a little bit about osteoporosis medications. A lot of people, they watch TV and they hear about these medications and they get scared. They don't want to take them. So common medications are listed here. We have one group of medications that are responsible for slowing down. Remember those osteoclast cells we talked about? Slowing down that bone breakdown. It doesn't form new bones, but it just slows down those osteoclasts. And the common ones are bisphosphonates, like alendronate, Fosamax, Actinol, Boniva, Prolia is another common. Some for the women, estrogen agents, raloxifene, Avista is another common one. The only medication that is FDA approved currently that forms new bone is teriparatide, also known as Forteo, and that's a daily injection. And you can only use it for 2 years. So that's the only medication that can actually build new bones for us. So let's talk a little bit about bisphosphonates, because a lot of patients would tell me, well, I hear bad things about that type of medication, so I don't want to take it. I'm just going to be careful and try not to fall. So the things that people hear and are afraid of is what Dr. Christensen kind of touched on: atypical femur fractures and osteonecrosis of the jaw, or the dying of your jawbone. So these things are very, very uncommon. These medications are not for everyone. Some people have side effects, really bad ones like stomach pain, heartburn, and acid reflux. And if you can't tolerate those side effects, there are other medications for managing your osteoporosis. So I wasn't really confident with Dr. Christensen going over this picture, so I have it here as well. But so your risk of having these rare complications like the jaw problem or those atypical femur fractures is less than 1 out of 1,000 people will actually experience these side effects or rare complications. And actually at Queens, last year in 2016, we had about 500-ish hip fracture patients, but we only saw 2 atypical femur fractures. So it's very, very rare. But your risk of having a a fracture without osteoporosis treatment is a lot greater. So if we looked at 1,000 women, 500 of them without osteoporosis treatment may suffer a fracture. So just to summarize, so what can you do about it? Well, we all should be doing the following things. We should all get adequate calcium and vitamin D, even children, adolescents, people without osteoporosis. We should all be exercising, right? Weight-bearing type, resistance type. Shouldn't be drinking too much alcohol. Smoking is bad, not just for your bones, but just your overall health. And falls, preventing falls. You can take all the medications you want, but you can start medications today, but you can fall tomorrow, right? Accidents are pretty hard to avoid, but Jeremy, thank goodness Jeremy's here. He'll kind of share some tips for us. And finally, bone density scan. You should get it if you're of age or if you have risk factors, and have your provider calculate your FRAX score for you. That's a pretty new thing that a lot of providers are not aware of today. And if you have osteoporosis, consider some medications. Talk to your provider to see what is best for you. If you want more information, you can go to these websites, National Osteoporosis Foundation and Own the Bone Program. Thank you. And so we'll have Dr. Britta Aramaki come and talk to us about polypharmacy.
I think I'm that tall. Okay. So hi, I'm Britta Aramaki, and I'm one of the geriatricians over at Queens. Oh wait. Sorry, let me get to my slides. All right, and then today I'll be talking to you guys about polypharmacy. So what is polypharmacy and why is it so important? Well, as a geriatrician, I take care of the frail and elderly patients in the hospital every day, and I'd have to say about 50% of the cases that I get consulted on are seeing patients who come in with a fall from the trauma team, and I see them with their complications with their fractures or their head bleeds or any sort of complication that they get from their injury and falling. And so the main reason why I chose this topic is because polypharmacy is one of the leading risk factors for falls in older people. So I'm hoping that at the end of this session, you'll be able to learn a little bit more about polypharmacy and how to prevent it from happening to you. All right, so what is polypharmacy? Well, there's no clear consensus on definitions, but it basically just means taking more medications than clinically indicated. So this can mean taking 4 or more medications, multiple medications in the same drug class, or multiple medications treating the same condition, and also includes herbal supplements and over-the-counter supplements as well. So what are the causes of polypharmacy? Well, a common cause of polypharmacy is actually having multiple medical providers that may not be aware of what the patient is being prescribed by the other doctors. Now, I'm not saying that your doctor is wrong for prescribing the medications that you need, but it can become a problem if they are not aware of what other doctors are also prescribing you, and it can be a problem. Prescribing Cascade is basically adding more medications to treat the side effects of previously added medications. So for example, for like nausea, constipation, diarrhea, and whatnot. And I'll be talking about this a little bit more in the next slide. And another cause is not reviewing medications with your provider regularly or taking old medicines that aren't needed anymore. So for example, maybe taking a cold medicine when you no longer have a cold, or an antibiotic when you no longer have infection. So this is a good cartoon that kind of describes what the prescribing cascade is. So as you see here, there's a female who is talking to her provider about her medications. And I'll read it to you guys really fast. So she says, well, the white pill lowers my blood pressure but makes my legs swell. The yellow pill lowers the swelling but causes me to pee. The blue pill stops me from peeing but makes me confused. The tan pill improves my memory but makes my nose run. The pink pill stops my nose from running but makes me sleepy. The orange pill wakes me up but increases my blood pressure. So the white pill lowers my blood pressure, and then you kind of see what goes on. So in essence, as you see here, if you look at the first medicine that she's taking to lower her blood pressure, but then in the last pill that she's taking, the orange pill, which is treating the side effects of all of her other meds, ends up increasing the blood pressure, and you can see where you have this vicious cycle that occurs. And unfortunately, this is something that can happen quite easily in medicine and something to be aware of and look out for. All right. So now that we know what causes polypharmacy, why is it a problem? So drug-drug interactions are obvious. Drug-drug interactions can result in inactivating a medication or causing another medication to have increased effects that you may not want. But polypharmacy can also cause drug-disease interactions where if you add in a certain medicine, it can make another medical condition worse or exacerbate it. There's also drug-food interactions where certain medications cannot be taken with certain foods because they won't work as well. Side effects. Every medicine does have side effects, and this just increases, obviously, as you add more. And then it can lead to poor adherence because it can be really difficult having to keep up with all of these meds and doses and various times of the day. And polypharmacy can be very expensive when you add up all the trips to the pharmacy from month to month, and you can see how the cost can rise over time. So this is just a simple illustration just showing how polypharmacy can lead to adverse reactions. So when you have someone who's taking various multiple medications, and then you add in supplements, which includes over-the-counter medicines, herbs, multivitamins, naturopathic remedies, various medical conditions, and then also certain foods, you can see where there's potential for adverse reactions if you're not careful or cautious, and this leads to the drug interactions and side effects that we just discussed. So who's at risk for medication problems? Now I'll be spending a little bit more time talking about the first two bullet points. So elderly people are going to be at increased risk because they tend to have multiple medical problems and they can accumulate these medications over time. And having multiple medical problems increases the risk for polypharmacy just because there's so many more conditions that need treatment. And some conditions like diabetes, hypertension, or heart failure require multiple medications for adequate control. But having said that, another thing to consider is that in the very old population, sometimes continuing to take a medication for preventative benefits can sometimes end up being more dangerous. So, for example, strictly controlling blood pressures or cholesterol levels can end up causing more harm from the side effects of low blood pressure, like falls or gait imbalance, or weight loss from the cholesterol medicine. And it's very important to keep in mind the potential risk and the long-term benefit when prescribing a medicine for the frail and elderly person. For kidney and liver disease, as we age, our liver and kidney metabolism changes, so it's good to take this into account when prescribing a medicine. And this is even more essential when you have underlying kidney or liver disease. Low body weight can affect the concentration and activity of medicines in your system. And they've done studies that show that 12 or more medication doses per day have been associated for more medication problems. Okay. So these are just some adverse outcomes from polypharmacy, and this list is just mostly due to the accumulated side effects from taking a lot of meds. So some, in combination or by themselves, can cause dizziness, lightheadedness, and affect your balance. And then that, of course, can lead to falls, leading to fractures or bleeds in the brain. Not monitoring your medications over time can cause stomach ulcers or GI bleeds, and also affect the kidneys. Constipation and urinary problems are common side effects of multiple medications. And then weight loss, confusion, memory problems, and fatigue can occur as a side effect, but also can be the result of just taking too many meds and can greatly affect your quality of life. And this is something that I actually see fairly commonly in geriatrics on the inpatient side. So this is common sense. The more medications a person takes, the greater risk of side effects and drug interactions. So they've done studies that adverse side effects increases with more meds. With 2 medicines, your risk increases to 15%. With 5 medicines, it increases to 58%. And then with 7 medications, it increases to 82%. Okay. So I'll warn you guys that the next 2 slides are kind of busy, so I apologize. But I don't expect you to know or to remember these meds, but I've just listed them so that you can refer to them later in your handouts when you go home. These 3 classes of medications require a prescription, and I'm singling these out in particular because they can cause a lot of problems in the geriatric population. So the classes are sleeping medications, muscle relaxants, and anti-anxiety, also called benzodiazepines. So all 3 of these classes can cause increased confusion, sleepiness, they can affect your balance, and therefore can definitely increase your risk of falls. They're all highly addictive, and it can become easy to become dependent on them in a relatively short period of time when taken regularly. When you take them for long periods of time, they can affect the memory and sometimes even resemble an early dementia in some. When I see a patient on any of these meds, I counsel them to stop, but they are pretty sticky medications and they can linger in the body sometimes for up to weeks to months to clear out. So I, strongly advise against taking any of these medicines on a routine basis just because they are pretty dangerous, or they can be very dangerous. Okay. So this slide is going to be another busy slide. So the last one was a list of prescribed medications, but this slide lists medications that you can get from your local pharmacy. So diphenhydramine, also called Benadryl, has similar side effects to the muscle relaxants, anti-anxiety, and the sleeping meds that I listed in the last slide. In addition to the confusion, sleepiness, and increased risk for falls, this class of medications can cause a lot of urinary problems as well. Diphenhydramine is an antihistamine, and it's frequently found in the cold and allergy medicines and many sleeping aids because of the sedative side effects. So be wary of all of the PM meds. So that includes the Tylenol PM, Advil PM, Aleve PM, because they all contain diphenhydramine. And so does the other sleeping aids like Unisom and Somanex. They're all found in the, in the sleeping aid aisle at the store. So because of these side effects, this is the primary reason why I tell my patients to avoid any over-the-counter sleeping agents, unless it's melatonin, because melatonin is pretty harmless. The other class of medicines that I wanted to discuss was non-steroidal anti-inflammatories, also called NSAIDs. And it's another class of medicines to be careful of because it can cause a lot of side effects like kidney failure, stomach ulcers, and bleeds, and it can increase your risk for heart attacks and strokes if taken regularly. So these are basically your Advil, your Motrin, Aleve. They help reduce inflammation, and it's okay to take it occasionally and in small amounts with food. But if you're taking it on a routine basis or regularly, you should really talk to your doctor so that they can be monitoring you. Okay. So now you know all about polypharmacy. I'm now going to go over some tips on how to prevent it from happening to you. So, first of all, it's obvious, but, read the labels because some of them may tip you off to some possible drug interactions. Learn your medications by name and what they're for, but if you cannot, make a list of all your medications, including the strength and the dose, and also include, herbal supplements, vitamins, homeopathic remedies, over-the-counter medicines, anything that you're taking that could be affecting your other meds. Carry your medication list in your wallet and bring it to every doctor's visit, and update it after every doctor's visit. And if you have more than one doctor, make sure that all of them know what the others are prescribing and give them your updated medication list with each visit. Take medicines only as directed by your provider. Use one pharmacy, if possible, to fill prescriptions. And the main reason for this is so that the pharmacy can have a running list of all of your current medications, and if there's any interactions or redundancies, then they can alert you and the provider about whether there needs to be a change. You can ask your provider or pharmacist to run your medication list through a drug interactions database to identify possible problems, especially if you're on 5 or more medicines. Never take a new drug without asking your pharmacist about its side effects and interactions with other drugs. Try to avoid combination products such as cold formulas. Now, the reason why this is in here is because a lot of cold formulas, if you look on the labels, they have 3 to 4 different medicines for various symptoms. And unless you're having all of those symptoms that's listed on the box, you're basically just adding more chemicals and meds in your system that could be interacting with your other medicines that you don't really need. So if you do have a cold or something, ask your pharmacist to help you find a product just for the symptoms that you're experiencing, not for every possible symptom. Don't share your medications, and then don't trust everything you read on the internet just because there's a lot of questionable sources out there. And if you have any questions, I think the best resources are maybe asking your doctor or maybe your pharmacist. Okay. So I know I went through a lot of information, but I hope you guys were able to come away with some tips on how to manage your medicines and how to prevent polypharmacy from happening to you. Thank you. And then Jeremy's up.
Okay, thank you. I brought my liquids up here in case my throat goes a little sore because I've had a little cold I'm nursing. Lisa, if I move around, will I be followed by the cameras? Okay, I'm going to come out a little bit from behind the podium then. So I'm Jeremy. I'm a physical therapist. Can you hear me? All right. I'd like to thank Lisa for her introduction because coming from the mainland, I'm actually an Italian. My last name is Angaran. But my dad says Angren. My grandpa says Angaran. And so I have kind of an identity crisis. I never really knew how to pronounce my own last name until I moved here. And really the way, because it's kind of Filipino, right? My last name, right? So, but it's really Italian. I'm Italian, but so Angaran is really pretty accurate in terms of how you say our last name. So I'm here to talk about how to prevent falls, and this is one way, right? This is one option. Just wrap yourself in bubble wrap and you'll be all right. This came out of Australia. I lifted it off the internet, so I'm sure that it was done in good humor and good fun. So there's really 3 take-home points here that I'm going to go over today. Our bodies will adapt. They'll adapt for the good, and they'll adapt for the bad. And so I'll go over some of that. Most people underdose exercise as we age, and so we'll go over some of that, why people underdose. Even therapists tend to underdose people as they age. And then lastly, if we can adapt and exercise more, we're going to have less of a fall risk. Okay. Does anybody know what this is? What is it? Treadmill in space. Right. Yeah, that's right. It's an astronaut on a treadmill in space. What's he got around his hips? He's got bands that are holding him on because otherwise he'd float away, right? But there's a reason he's doing this. What happened is when people are going up into space, they're going for longer and longer. And when they would come back down, they were noticing that in that time up in space, the body, because of the lack of stresses being placed across it, would adapt, in this case, kind of for the worse. The bone would get weaker, they would lose a little bit of their muscle. And so some of these astronauts coming out of space, if they were up in space for a long time and they weren't doing this, could barely walk. In just a matter of, a couple of months, it can have that significant of an impact. These are healthy younger people, right? So you can see what that lack of activity can do, that lack of stress. It helps our body reacts to that stress all the time. Gravity's pushing us onto this earth so we don't float away. That's a good thing for us. It helps us, our bones get stronger, but we also have to participate in some of these activities. So this is a fun slide. I teach this to patients. I've been teaching it for a long time, but I've never really had my own version, so I made it. But what it is you can see, this pointer is really light, but on this left side is stress, and then we have strain over here. And so as the stress goes up, there's this eustress zone. I'll use the pointer here. This eustress zone is a good zone. That's where the stresses are good. That's in here, okay? And eventually you get enough stress that you'll get into this injury zone and then severe injury. And so this is based on some of the properties of the tissues in our body. And so basically, if you had a stress and you're pushing, at some point it's going to break, right? The tissue is going to give away, whether it's a ligament or whether it's bone, whatever it may be. And so the take home on this is this good zone, it has to do with how we do our activity and our exercises. As long as we can stay in this good zone and then rest, each subsequent time our body is going to heal, but it's going to heal back a little bit stronger. And then that curve, you can see how it's building up. That's because we've stayed in that eustress zone. And so I'm going to teach you how to do that in some of the following slides, how to stay in that good stress zone without injury. So this is a fascinating slide, I think. So you've got at the top, this number one is a young 40-year-old triathlete, and that's a cross-section of the leg. Number two is a 74-year-old sedentary man. Number three, 70-year-old triathlete. Look at the comparison between number three and number one, a 40-year-old and a 70-year-old. Now, they're both triathletes, but look at how significant of a difference that is between number two and number three. They're only 4 years different in age. Number two, all that white you see, that's fat. That's fat tissue. And the muscle is the dark stuff in between, and it's really marbled, and you can even see the color of the muscle, how different it is in the MRI. So the take home on that is this person, this 70-year-old triathlete, has muscle, probably bone, of someone half his age. So it's doable, okay? So the next part is on dosing exercise. You'll see a lot of people as they get older, they start doing these exercises in here, right? Where they're sitting in a chair, doing this kind of stuff, right? Good, right? I'm exercising. This picture here, I wonder if, let's see, does that look like me? It's my dad. He's 70, and he goes to boxing class twice a week. It's actually a Parkinsonian boxing class. Sorry. I get choked up because it's just awesome. He's such a fighter. So the take home is you can still fight, okay? And this is the kind of activity that we want people doing. We want people pushing themselves, but we got to do it safely because we don't want people to get injured. So this is an interesting study. What happened is they took a poll of all the physical therapists in the country. Not all responded, but they took a poll. And they asked them what things shouldn't be done in practice. And one of the responses was the wrong kind of strength training for older adults, and that's in this column over here. And one of the things they said is, even in therapy, the exercise might be too easy. The therapist may be afraid that you'll be hurt. And that happens. I manage an outpatient rehab clinic. I've treated patients, and it happens. You're worried that you don't want to stress that patient too much. You don't want to push them too hard. But you know as the patient, is anyone here getting therapy? Let me see a hand or two. Okay. You know if you're ready to, and if you're being pushed hard enough, tell them. If you feel like you need a new challenge, or if you need to be pushed a little harder, okay? Tell your therapist, because this is a problem in our profession, that we undertrain people. It says, studies show that a challenging program offers the most benefits, even for seniors and nursing homes. The therapist should match the program to your abilities. When you can do the task easily, the therapist should add weight, repetitions, or new exercises. The harms: if strength training isn't challenging, it's a waste of time and money. You will still have problems from weak muscles, and you will still be at risk for falls. So how do we dose exercise? What goes into dosing exercise? This is another one that I teach patients and have taught for a long time, but haven't had the tools to do it with, and so I created it. But basically, you're looking at frequency. How often do you do the exercise? The intensity. How hard are you working out? Duration. How long are you working out? And then the mode. So whether you're running, biking, swimming, maybe you change shoes, or maybe you're on a new surface. So this is an example of dosing exercise. So maybe this person's baseline on the left, they're doing twice a week a 10-minute walk. A very light, not resistance, but stress, okay? But if you do a rapid change or increase in any of those 4 areas, like in this demonstration, you have an increased risk of injury. So let's say you're motivated by me tonight, and you're like, man, I'm going to go home and I'm going to walk. I'm going to walk. I've been walking twice a week, but now I'm going to do it 7 times a week. That's potentially going to be a problem, okay? We want to build slow, and I'll show you how to do that in the coming slide. Similarly, let's say right now your baseline is that you're doing 10 minutes of walking twice a week, but now you're like, he inspired me so much, I'm going to run. Okay? Well, that's changing the intensity, right, from very light now all of a sudden to a maximal for you, and that's a potential risk, okay? So this is what that looks like, and this is called pain contingent behavior and pain contingent exercise. Another one that I created the graph of to help demonstrate a picture of what we see. So activities on the left, right? Activity as it goes up. Let's say you decide you're going to go out and you're going to do a half-hour walk, and your baseline is 10 minutes. But then your pain goes up. You see that orange line? And you're like, oh man, that was kind of sore. That hurt. I'm going to rest. And then your activity goes way down here, okay? Let me come over so I can show you where I'm at on this. Can you see the pointer? So activity goes up. Oh, I'm kind of sore and hurting. I'm going to rest. Rest. Activity. Oh, I'm feeling good again. I'm feeling really good. I'm going to go for a half-hour walk. Half-hour walk, go up here. Oh, now I'm kind of sore. Or this time I'm going to run. And now maybe you get injury, maybe you get tissue distress, maybe you get pain, right? So now you come back down here with no activity, and it takes longer, right? You just sit there and you're recovering, and you think, man, I'm feeling good again. I'm going to walk. And you go do a half-hour walk, and you're just riding this roller coaster, and your activity level just kind of stays the same. And what this graph is trying to depict is that if we can just do it more of a dosing of our exercise and try to increase it by about 10%. I said a day here, could be 10% a week. I'll take you through an example in the next slide. But if we can just try to be scientific about it, whether we feel good or bad, each day, the next day, we're going to do just a little bit more. Or each week, we're going to add that dosing. And just think about it, 10%. It's not 100%. And thinking about these modes, it's really going to help you have some success. And believe it or not, we've done this in our clinics. And you can take people that have severe pain problems and ride this up and down, this pain contingent, and they can increase their activity well beyond their level in a rapid time just by following this pattern. So here's an example. You got a baseline, very light exertion with a 10-minute walk 2 times a week. Okay, that's the baseline. So day 1, twice a week, right? So day 1, you're going to do a 10% increase, so 11-minute walk. Okay, we're at twice a week, right? Day 4, which would be kind of 2 or 3 days later, twice a week, you're going to do a 12-minute walk. And your total is for the week is about 23 minutes. Then maybe the next week you're going to do twice a week still, but bump it up by another minute per walk. And now your weekly total is up to 27 minutes. And then you get to day 14, or day 11 and 14 would be the, I guess, the second week there. So what should you do if you decide, wow, this has gotten kind of easy. I'm twice a week. I think I could bump it up to 3 times a week, right? So let's go back. Oh, we got it down here. Think about these things. We're bumping up the frequency. If we want to keep our dosing by increase a little, what should we change? Duration. I heard it. Duration is right. Yeah? Because you're bumping up the frequency now. And now you're going 3 times a week. So if I drop the duration down to, let's say, what do you think, 10 minutes? 10? Yeah? The first day. Then 11 the second day. Then 12 the third. I'd be at about 30 minutes of walking for the week, right? You see how that goes? So whenever you bump up one, you got to think about the other and drop it down, balance it out, but you still want to progress, right? You still want to make it a little more challenging on yourself. And then hopefully we can get you to the point where you're really beefing up your exercise. So the last one is to stress yourself carefully. Get that guidance from a professional. Physical therapists obviously can be a good starting point if you're not really sure, where your baseline is or what it is from what I've said. But push yourself and you'll get stronger. If you don't push yourself, you'll probably get weaker, as those slides showed. So here's a study that came out recently, and basically the take home is at the bottom. 3 hours per week of exercise, that's a lot of exercise, including high challenge to balance, reduces falls by almost 40%. So the evidence is there. It works, but you got to do it. So for preventing bone loss and falls, I'll come over here. We're basically recommending a combination of strength training for major muscle groups more than twice a week, balance challenges, and moderate to vigorous aerobic physical activity greater than 150 minutes a week. That's a lot. And that's you should be doing all 3 of those regularly. That will help a lot. Reducing spine loads, so we're talking about the risks of fracture, and the example was given earlier that somebody coughed, right, and fractured. Those things are going to be hard to prevent, but there's things that we can do when we're handling things and lifting things and carrying things that can protect our spines. Some of those things is what we call hip hinging, is when you're bending over, bending kind of at the hip, but keeping the back kind of straight. Some people will do like the golfer's pickup, where you reach over, the leg goes straight, but it reduces some of that stress on your back. You have to have good balance for that. The other one is the twisting, right? When you're grabbing things, twisting versus turning your body. This is preferred, right? Move your feet. You're going to have less incidence of that strain on your back. And then last thing is keeping the load close when you're carrying things. Keep it close to you, okay? So I included a few resources for you that you can look into. Some of them are local, like this Tai Chi. Tai Chi I didn't hit on too much earlier. Does anybody know what Tai Chi is? Does anybody do Tai Chi? Raise your hand if you do Tai Chi. Cool. Yeah, good. This Tai Chi is excellent, and there's a lot of science and literature out there that Tai Chi is effective at reducing falls, because it's a lot of balance work, right? So there's local classes. You can look them up. YMCA has an enhanced fitness program. Of course, we have our rehab services here. And then there's a little worksheet that you can work yourself through for some of those exercises, okay? All right, thanks a lot.
Thank you, Jeremy. At this time, I'd like to call up all of our speakers to take to the stage. And if you have questions, please raise your hand and we'll come out to you.
Oh, good question. I'll try to repeat it. Go ahead.
Thank you all for sharing very interesting information. We've got two questions, very short one from Mary. I noticed on the nutrition of calcium chart with the different foods, it specified spinach and broccoli, but they were cooked. I understand most of the time when you cook something, you take some of the nutritions out, so just wondering why it was cooked. And secondly, for Dr. Christensen, I've got a old orthopedic surgeon, a friend of mine, that is all into stem cell regeneration now. He's regenerated his own knee and is very adamant about that, and I'd like to hear your thoughts on that. Thank you.
You do the cook one first?
Sure. So the question was for spinach and broccoli, if they were cooked, does it have less calcium versus the uncooked? Usually, this gentleman mentioned if it's cooked, it takes away nutrients. So I think that the National Osteoporosis Foundation listed the cooked version because most people eat cooked version. So if you were to cook your vegetables, that's how much calcium you'll get. But you're right, if you don't cook, if it's uncooked, you probably get a little bit more calcium.
Stem cells. Well, the problem with me with stem cells, where you either do the platelet-rich protein injections and things like that, the science is getting there. The problem with me is getting it funded either for injections and things like that. Most insurance companies aren't really paying for either stem cell injections for regeneration of cartilage but every once in a while I'll get it funded, and it seems sometimes to help at least reduce the pain. So I got nothing against it. I just have it's kind of expensive already, and a lot of times the insurance companies just say there's not enough science at the present time to fund either the injections or the nutritional supplements for stem cell research. That's what we're on right now for it. Okay, I mean I have sort of nothing for or against it. It's just like when you come with a $500 bill for the injection, I don't. A lot of folks will say, well, I'm not going to do that today. Okay, so that's where I'm at. But sometimes I'll get approved through the insurance companies for platelets.
Thank you. We have a question there.
Are Tums a useful calcium supplement?
Yeah, so Tums it's a form of calcium, but you will need to check to see how much calcium it actually contains. So you can read in back of the bottle to see, but it is a form of calcium as well.
Okay, we have a question here.
Hi, no one mentioned the role of the sun in getting in vitamin D. Is that important to get so many minutes of sun a day on your body?
Yeah, so the sun is the most natural form of getting vitamin D, but especially in Hawaii where it's mostly sunny, but we're finding that most people are wearing sunscreen now because you want to protect yourself from skin cancer, right? Or from getting dark or whatnot, or tan. So with the sunscreen, you're not getting that absorption of vitamin D, not the same absorption. You can, yeah, yeah. But probably not enough, that is recommended.
But we don't have anything that's 80% in medicine, okay? I mean, 80% is a big number, and 80% of the people were vitamin D deficient, okay? So, yeah, the sun's good, and we got a lot of it around here, okay? But there ain't nothing in medicines at 80%. And that's what when people that break their bones, the vitamin D deficient, and it's a fairly safe vitamin to take, already, and I'm encouraging it. My wife takes it, okay? So. And she gets out in the sun a lot too. Okay.
I have a question for Jeremy. I'm a little bit confused. I'm 83. I have had a hip replacement and a knee replacement, and I exercise at the Y pool with water aerobics. And now I've been told by a physical therapist that it isn't enough. It's not weight bearing enough, even with water resistance. So I'm a little confused because I thought I was doing the right.
I think I can't, maybe the second or third to last slide. So that would be good cardiovascular exercise, which is great. But you're missing that resistance component, right? In terms of the weight bearing. And so typically, the recommendation I would make is a combination, right? So use that work that you've been doing in the Y pool, continue it because it's great. It's activity. You're getting your heart rate up. But maybe incorporate a couple of different modes if you can. I don't know what you're capable of, with the prior injuries, but maybe you're able to do some bicycling on the bicycle trainer, or even walking, short walks. I don't know. You know what I mean? Everybody's got a different baseline, but yeah, to incorporate different modes is ideal. To be exclusive to one mode without that resistance is less ideal. Does that answer your question?
Okay, we have a question here. I'm taking Prolia shots every 6 months, and I wonder how effective is it? Because I used to take Fosamax, and I asked the doctor about continuing to take it because I've been taking it for a while. And I stopped taking it, and he prescribed Prolia.
Take that one, Britta?
Yeah, I can take it. So bisphosphonates like Fosamax usually is recommended for you to take for about 5 years. So those clinical trials that we do for bisphosphonate, the max is pretty much 5 years, and your doctor probably switched you to a different class of medication like Prolia. It works a little bit differently than bisphosphonates, and it's probably because you've been taking bisphosphonates for a little bit longer, or you've reached the 5 years, and that's why they switched.
Okay, we have a question there.
Yeah. How important is magnesium as a supplement to strengthen the bone? Because I've seen some preparations of calcium that has magnesium on it and some don't. So should I supplement with magnesium if there is nothing on a preparation that I'm taking as far as calcium?
So, calcium, magnesium, those kind of electrolytes in our bodies, you need an equal balance it complements each other. So you can take magnesium, but you want to check with your provider first to see if magnesium is something you want to add, because it can affect your bodies in different ways. You don't want to take too much, you don't want to take too little. So always talk to your provider first about your individual condition.
The one thing I wanted to add about the magnesium is if you do decide to take it, just be careful, because too much can actually cause a lot of diarrhea and gastrointestinal problems. So just be cautious.
Milk and magnesia.
I'm wondering what your thoughts are on Forteo, and when would you recommend using Forteo versus, say, Prolia or Fosamax?
I like Forteo. It's a great medicine. I mean, it kind of takes it's an acquired taste because you have to give yourself an injection already once a day for 2 years. It's the only one that Mary presented up there that's a bone building one. All the other medicines are what they call anti-resorptive, which means they kill the osteoclasts, which are supposed to be the eating the bone. And so, and it goes back to my stem cell question. All right, the problem. It's a good medicine. You got to know that you're going to give yourself an injection. It's very costly. And you usually have to go through quite a bit of a process to get it approved already, you know, from the insurance carrier, because I've had patients that, you know, that tried to buy it. It's just really expensive. And so you've got to go through a process of saying, I did a bisphosphonate, it failed. Usually you have to have a DEXA scan or something proving you have osteopenia, osteoporosis, or some sort of failure of the bisphosphonates in the treatment of that. But it's a pretty good medicine, and the only really contraindication to it is an existence of a sarcoma in your past history. All right, so but it's a good medicine, but it's hard to get approved through an insurance carrier, and you gotta like stick yourself. All right, some people just say I ain't doing it because I gotta stick myself once a day, and I understand that. I think I'd kind of grump me a little bit. All right. Did I answer the question good enough?
I had jaw pain from Fosamax, and now I'm taking Prolia. What are the chances of me having the same side effects from Prolia? And so if you say every 5 years, you should switch. So I'll be taking like different ones as I get older, switching like every 5 to 7 years. How does it work?
Go ahead on that one.
Yeah, so the bisphosphonates are the ones you should, you know, take about 5 years or so. Prolia doesn't have that same risk factor of getting that jaw, osteonecrosis of the jaw. And, you know, when you're on medications, you should still get the bone density scans to make sure the medication is actually working. There are also other lab values that your provider can order for you, like bone turnover markers to check to see if the medications are working for you.
Have you had fractures? Oh, good. Okay. Well, then I mean that's the most important thing. I mean the treatment comes when you had the fractures. That's the big deal. Okay, and whether you want to do it. I mean that's what, you know. It's a silent disease, which means, you know, hey, you know, I'm going along and I'm doing fine, and all of a sudden I break something that when I just fall, and that's the deal. That's the biggest thing. That's what the fracs you know, method of determining osteoporosis is good for. It takes this fracture history more importantly. I don't like that, but it's good, you know. And then you know, you want to know if you've got the osteoporosis, and the DEXA scan and the frax usually helps you out, and then you decide whether you want to, you know, go through the bisphosphonate thing. Okay.
We'll take 2 more questions. Is there one on that side? Raise your hand.
Yes, I'm a golfer.
Yep.
And I saw that slide where the woman had osteopenia, where she thought that she fractured something, so then it was like she probably had osteoporosis. And so if you have osteoporosis, should I consider playing darts instead of playing golf?
Well, I'll answer. I'll let Jeremy comment. Okay, I have a thing I say, you know, that I like a lot is motion is lotion. Okay, I think golf is motion. Okay, and it does kind of make you, you know, like, you know, all the golfers, you know, they got back pain. So be careful of your back. Make sure you're doing, you know, the resistant things. To me, more of a problem with the golf is that, you know, you can aggravate your back if you hit a duffer or something. You know, so it's a good exercise. Motion is lotion. You know. And then if you ever, the big thing is have you had a fracture yet? Okay, you'll probably be all right. Okay, so all right. No. Jeremy?
I have nothing to add. I think, seriously though, that if you've been doing it and you haven't had any difficulties, think about that frequency, intensity, duration. and maybe even the mode, right? So if you've been golfing X amount of times a week, or maybe you normally do 9 holes and all of a sudden you're like, I'm going to do 36 holes, that's the opportunities for you to increase that risk. If you're performing at a baseline right now without difficulty, then you probably could increase on that baseline just a little bit, and be okay. The main risk, of course, is just getting to that distress zone where, you get that tissue failures. And it's always going to be a part of it, but I think the activity in this instance would probably outweigh the risk for me. If it was me, I would probably still want to continue with the activity. It's more important.
Okay, we have one more question, last question there.
Yes, could someone comment on the fairly recent information about high calcium intake, dietary or supplement, causing cardiac issues, calcification in the heart, things like that?
Yeah, so I've actually seen those studies with if you're taking too much calcium, it's very rare. It can cause what they call atrial fibrillation in the heart if you're taking too much. So, and that's why it's important to know what is the recommendation, the dosing for yourself, and read the labels, and be cognizant of your food, and if you're taking supplements, just make sure you're not taking too much. It's very rare, but there are a few cases that can cause atrial fibrillation. It's a irregular heartbeat in your heart, but it's very, very rare. And those patients usually have other, health issues that they're already high risk for these heart problems, and they were taking maybe too much calcium.
It's kind of like your mom said. Mom's really smart. If a little's good, more's not better. Okay, most of the ones were just going crazy about the calcium that made the go, and my mother-in-law is the worst. Okay, I mean her pill bottle is huge. Okay, so they got calcium. I said, oh, come on, Martha, take a little less. Okay, and she won't do it. Okay, you never tell your mother-in-law anything bad. So that'd be bad. But I think if you take your 1,500 milligrams of calcium and vitamin D, I'm going to go home with the vitamin D. Okay, that's important. Okay, you don't get 80% in medicine in anything. So okay, but don't go crazy on the vitamin D either. Okay, it's about, we used to say 400 international units. Now it's about 1,000, right? So that's a good thing. All right. So I guess we're gonna call it good. All right.
Yes.
And but we'll be out and hang around if you got questions. If we didn't get your question, we'll be happy to answer them. I mean, I just don't want you to have to meet me, okay? Except maybe at Ala Moana, okay? I mean, it's my stuff is dangerous, and so don't take any medicine you don't need. All right, get your calcium and vitamin D, get your resistant exercise, and you're going to do good. All right.
Okay, let's give a round of applause for Dr. Kevin Christensen, who you never want to meet, Mary Mitsunaga, Dr. Britta Aramaki, and Jeremy Angaran for sharing their time this evening. I also want to say mahalo to our volunteers, James, Steve, and Laura, if we could give them a warm round of applause.
That's the yellow shirt, folks.
Again, we're going to have this recorded and posted on our Queen's YouTube channel in 1 to 2 weeks. I want to tell you a little bit about our next lecture. It's called What's Going On with My Body? And it's not something to do with like body snatchers or aliens invading your body, but it's hormonal changes, so it's from within with aging. And our Dr. Alan Parsa is going to talk about androgen for men and menopause for women. He's going to talk about whether the estrogen and testosterone levels really change as we age. Why are these hormones important to us? The signs and symptoms that your levels may be low. Also, what can or should be done, and if there are risks involved in taking these hormones. And that's coming up Wednesday, April 26th from 6 to 7 p.m. You can sign up for it by calling our Queen's referral line 691-7117 or going to our Queen's website and registering that way.